There we go. I'll try and make it quite straightforward. The first thing to say is that whenever you're faced with any kind of medical diagnosis, particularly cardiological diagnosis, it is overwhelming. It is overwhelming. It is like, you've got all this jargon, you've got all these tests, you've got different people calling the same thing by different names. Horrendous. I completely appreciate it. And this same thing happened to me when my dad was ill earlier this year, and I had the opportunity to become a patient, just a relative, and I started seeing things from the other side, and I could see exactly how scary, lonely, and overwhelming it is. So I'm going to try and break it down to really simple things, because if you try and understand it and ask yourself a few questions, you'll be able to make sense of most things. Okay. So the first thing always is, no condition is a condition unless it does one of two things. It has to either impact on our quality of life, or it has to impact on our length of life. Right? Those are the only two things that are important. Life, as far as we're concerned, has only two dimensions, quality and quantity. And therefore, anything which anyone says, if they say, oh, you've got this, it's only worth bothering about if in some way it's going to make us feel unwell, affect our quality of life, or in some way it'll shorten our lifespan. And therefore, whenever you talk about any treatment, management, etc., all treatment has to either make us feel better or in some way make us live longer. Right? So that's an easy way to try and understand it. Whenever you're faced with anything, say, what does it do to me? And how does the treatment impact me? The other thing always I think it's really important to understand is that anything, there are two things to ask about anything. When you're thinking about it, you're going to think, well, I have this thing. Is this a sign of something else? Is there something going on in my body that caused for this to happen? Is it a symptom? Right? And because if it is a symptom, that what you want to try and address is the thing that it is a symptom of, rather than just treat it as the symptom, right? Because otherwise you don't tackle the underlying problem. And then the second thing you have to ask yourself is, okay, I appreciate it's a symptom, but can this in itself harm me in some way? And the NHS and most doctors are really focused on this idea that actually it's the thing, and they don't think of it as a symptom. They think of it as a condition. They want to calm it down, and they're bothered about what that thing may do to you, but they largely ignore why you got there in the first place. And I'm hoping that when I talk about this, it'll help you understand some of this. And once you have those questions in your mind, it'll make it easier for you to understand what I'm talking about. So understanding atrial fibrillation. Now, the first thing is, what am I going to talk about? I'm going to talk about what is atrial fibrillation. I'm going to talk about how common is it. I'm going to talk about how it affects our lifespan. How does it affect our length of life? Then I'm going to say, well, what can you do to improve your length of life? Then I'm going to talk about how it affects our quality of life. And then I'm going to talk about why, or what you can do to improve your quality of life. And it's really, really important not to confuse length of life and quality of life. Right? Because length of life and quality of life are not related. I'm happy and I feel fine, but I could be hit by a car tomorrow. I have a great quality of life, but that doesn't guarantee a length. And that is why people wear seatbelts in their car, because they understand that actually how they feel that day has no impact on what happens to them. So it's always important to think of it like that. The first thing is, oh, crikey, sorry, I must put this on charge because the thing is going to die otherwise. Sorry. Give me 2 seconds. Perfect. Okay, so atrial fibrillation is a heart rhythm disorder. It is by far one of the commonest heart rhythm disorders we come up. Let me just, sorry, this is all. Let's just plug this in. Does this come on? Should do. Sorry. Okay, let's hope this works. It should work. Okay, perfect. So atrial fibrillation is a heart rhythm disorder. It is one of the commonest heart rhythm disorders that we know of. It is characterized by an irregular heartbeat. The heartbeat is irregularly irregular. So if I don't know how many people have ever felt their pulse, but if you feel your pulse, it will be fairly regular. It's very, very consistent. Atrial fibrillation, it becomes completely chaotic. Now the question is, what does that mean? The first thing to say is that any heart rhythm disturbance, when we're thinking of heart rhythm disturbances, the only relevance of that heart rhythm disturbance is that during that heart rhythm disturbance, the heart becomes, as a pump, becomes inefficient. That's it. The heart is a pump, so the mechanics of the heart are the most important thing. Okay, you can put as much electricity into a heart which doesn't have any strength, and the heart will not beat. That is why people who have pacemakers don't live forever, because if the heart muscle itself is dead, you can put as much electricity in it and the heart will not beat. Equally, well, you can have patients who have no electrical activity in their heart, but the heart beats fine. Those are people who have these things called left ventricular assist devices. So their hearts are so weak that someone actually puts in a pump to support the heart. So in those people, because the mechanics of the heart are being augmented by this device, it doesn't matter whether you have any electricity in the heart. So it's always really important to understand that actually what is the important thing here when you're looking at any electrical disturbance. Eventually it is that it causes the heart to become inefficient for the duration of that electrical disturbance. And that's it. And it is that level of inefficiency that it exposes the heart to, which decides whether the rhythm is dangerous or not. In terms of heart rhythm disturbances, you can have non-sustained rhythm disturbances, 1, 2, 3 heartbeats going out of sync. They have no meaning whatsoever. They are not dangerous. They are clearly not dangerous. Okay, someone can squeeze my neck for 3 seconds and nothing bad will happen to me. It is only that if someone squeezes my neck for, say, 5 minutes or something, that's when it becomes dangerous. So similarly, all non-sustained heart rhythms are not dangerous at all. Atrial fibrillation is a sustained rhythm disturbance. What do I mean by sustained? It goes on persistently for more than 30 continuous seconds. That's the definition of between non-sustained and sustained. So sustained heart rhythm disturbances are important. A lot of people will come to me and say, I'm getting ectopics, are they dangerous? I'm getting extra beats, I'm getting flutters, missed beats, etc. No, they're not. By definition, they cannot be dangerous because they are so transient. The inefficiency placed on the heart is so small, so short-lived, that they cannot possibly be dangerous. In atrial fibrillation, it goes on for more than 30 seconds. The way to think of atrial fibrillation is to think of an old-style galleon. I use this analogy in my clinic when I'm trying to explain atrial fibrillation to patients. You think of an old-style galleon, and you've got slaves sort of pushing this, rowing forwards this galleon. And you have 85 strong slaves at the bottom who are doing the majority of the work. These are the ventricles. They do 85% of the work with your heartbeat. You have 15 weaker guys at the top. They're the atria, okay? And then the captain of the ship is one of the 15 weaker guys, much like our current political leader. His job is twofold, okay? He tells everyone to row in a synchronized fashion, and he tells everyone how fast or slow to row depending on the conditions of the sea. That's what he does. That is our pacemaker. So, if you get everyone to work harder for a long period of time, the 15 guys at the top are inherently weaker, and therefore they give up. They get tired and they decide, we can't do this, we're going to stop working. Now, sometimes they stop altogether. Sometimes they stop transiently and take up war again after a little rest. But that condition where the 15 guys at the top give up is called atrial fibrillation. So 3 things happen when you have atrial fibrillation. the heart will lose 15% of its efficiency because you've only got 85 guys doing the job. The 15 guys have stopped working. Number 2, the heart will start beating irregularly because the captain of the ship was one of the 15 guys and he was telling everyone to beat in a synchronized fashion. And number 3, the heart will beat too fast or too slow, maybe too fast or too slow for what the person is doing at that time. Again, the captain was telling everyone how fast or slow to row. When the captain isn't working, they may row too fast. So atrial fibrillation is a condition both of heart rhythm, the rhythm becomes irregular, and the rate, where the rate may go excessively fast or excessively slow. Does that make sense? Excellent. So the question then is, well, why does it happen? Okay, it can happen because of stormy seas. So everyone's just having to work harder because the seas are bad. Or it can happen because the oarsmen are particularly weak. So in terms of stormy seas, age, high blood pressure means the heart has to work against a higher pressure. That's why diabetes, again, diabetes causes all our small blood vessels to narrow, our blood vessels get less stretchy, and therefore everyone's working harder. Smoking, obesity, sleep apnea, infections, they all make the heart work harder. Or you may be blessed with weaker atria. Your oarsmen, your 15 guys may be just constitutionally weaker than everyone else. And that could be because of genetics. And we know atrial fibrillation has a genetic bias. It can be due to alcohol, which weakens our heart muscle. It can be due to caffeine, although some people now, there is some research which says no, caffeine is not implicated in atrial fibrillation. However, I did a poll on my Facebook page and 45% said when they drank caffeine, that would push them into atrial fibrillation. So stimulants, cardiomyopathy, so if you've inherited weak muscle, and viruses can cause. So those are the causes of atrial fibrillation. It can come and go. So you can get the 15 guys giving up for a little while, taking up or again, or they may just give up altogether. When it comes and goes, it's called paroxysmal. It means you're getting paroxysms of atrial fibrillation. When it stays irregular, it's called persistent. It affects 2.4% of the population. If you randomly go and shake hands with 100 people and feel their pulse while you're at it, 3 will have atrial fibrillation. You will pick up 3 cases of atrial fibrillation. So the interesting thing is, only 2 of them will know they're in atrial fibrillation. 1 of them will have never known that they're in atrial fibrillation. You will be making the diagnosis for the first time. So at this point in time, only about 2/3 of the patients with atrial fibrillation are diagnosed as having atrial fibrillation. And there are all these people at risk. So about 500,000 people in the country are undiagnosed, and it may be a lot more than that. This is the tip of the iceberg. Atrial fibrillation undoubtedly increases with age. In fact, once you get to 80, 1 in 4 people will have atrial fibrillation. Okay, in York here, there are about 3,000 undiagnosed cases. How do we know? We have data from other places which tell, where so if you extrapolate, that's what you think. Because otherwise you'd say, well, how do you know if they're undiagnosed? But that's how we know. So why is AF increasing? AF is increasing. This is one of my favorite slides. You've seen it lots of times. But this has taken us millions of years. And now this has taken us 150 odd years to get here. And this is one of the fundamental reasons why atrial fibrillation is increasing. A lot of people talk about the fact that we're getting older. The reality is we're getting fatter. That's the main reason. And in any case, we can't do anything about getting older, but we can do something about getting fatter. Now, the question is, how does it affect lifespan? And one has to take this very carefully. So it's not as horrible as it looks, but I'll try and explain it to you. But in general, if you look at all the data, there does appear to be an increased risk of all-cause mortality. So overall, people with atrial fibrillation tend to die more than people who don't have atrial fibrillation. There is some evidence that atrial fibrillation increases our risks of heart failure. Now, that may be firstly because people with weak hearts develop atrial fibrillation anyway, so they're going to be more likely to have heart failure, etc. So sick people tend to develop atrial fibrillation and sick people tend to die. So it doesn't automatically mean that the atrial fibrillation is causing people, but it's just bearing in mind that it keeps bad company. So if you have atrial fibrillation, generally if you have other things going on, they all contribute to a worse prognosis. But the most important thing, and the thing that everyone talks about, is the fact that atrial fibrillation is associated with strokes. And the buzz, the big message is that your risk of strokes goes up by 5-fold if you are diagnosed with atrial fibrillation. This is not true for everyone, but I will explain that. If you look, however, that actually if you look in women, the risk of stroke goes up even more compared to men. So once women are diagnosed, their risk of stroke is higher with atrial fibrillation. So if you look over here, this is men. If you look at women with atrial fibrillation, the yellow line, much higher. And that is why when they're calculating risk scores, they give you a point if you're a woman. In terms of atrial fibrillation and stroke, they find that 15% and maybe more than 15% of all strokes are attributed to the presence of atrial fibrillation. A third of strokes, more than a third of strokes in octogenarians is due to atrial fibrillation. What is really interesting is these young people who have strokes. There are lots of young people nowadays who are coming to the fore who've had strokes for no good reason. There was an interesting study called the Crystal study where they actually implanted little monitors in their chests, and over a course of 2 years, 36% of those people were found to have atrial fibrillation. So one of the big problems at the moment is that when you have a stroke, if you've never had atrial fibrillation, the current practice is put on a 24-hour ECG. You're not going to pick up anything on a 24-hour ECG. When you put in a monitor, a third of those people who have a stroke are subsequently found to have atrial fibrillation. Why is it important? Because it changes how you treat them. That's why it's so important to pick it up. And those people who have atrial fibrillation-related strokes have worse strokes and worse outcomes from their strokes compared to patients who don't have atrial fibrillation. So that's another thing just to bear in mind. And we know that atrial fibrillation keeps bad company. Atrial fibrillation happens in patients who have stormy seas or weak oarsmen. So by definition, they have other things going on. The question really is, does atrial fibrillation cause strokes, or is atrial fibrillation a marker of someone who is more likely to have a stroke? That's really important. It's really important. Do you know why it's really important? Because if atrial fibrillation causes strokes, you should do everything you can to try and get rid of the atrial fibrillation. But if atrial fibrillation is a marker of someone who is more likely to have a stroke, then you have to deal with those things that are the thing that causes the stroke. Right? And this is where we go wrong at the moment, because atrial fibrillation, everything's geared towards the atrial fibrillation. So I'm going to show you some really interesting studies. Okay, there was an interesting group of, there's a guy called Bernard Gersh, Professor Gersh, very, very highly respected, venerated cardiologist. He did a really interesting study. He took 97 people who had atrial fibrillation, but they were young, under the age of 60. They didn't have diabetes. They didn't have high blood pressure. They had no risk factors whatsoever. They were just healthy young people who'd suddenly found themselves as having atrial fibrillation. So he chose not to treat them, and he followed them up for 15 years. And he found nothing bad happens to them without treatment. These are people who have what is now known as lone AF. AF in the absence of comorbidities. No comorbidities, nothing bad happens to you. He then did a really interesting study where he took all comers, people with lots of comorbidities, people with above the age of 60, age of 65. And he was really interested in saying, well, what happens to these people now? And what he found is that within 3 years, half of them had actually died. So the question then arises, it's the same AF. You've got one group of patients who've got AF, no other problems, nothing bad happens to you. Another group of patients who are older, who have diabetes, who have high blood pressure, etc. Terrible things happen to you. So is it all about the AF? Or is it about something else? And this is where a lot of our management of AF is based, because the first thing they do when you are diagnosed with AF is they start marking this kind of calculating a risk score for you. And I'll show you this. But what this made me think is, does AF cause a stroke? And certainly not on this data, it doesn't, right? Either these people have two separate diseases, or the AF is not the cause of stroke. So then I became interested and I started looking at this and I thought, okay, there was some really interesting studies done where people who have pacemakers, people who have monitors already in their hearts, people started looking at these, because if you have a pacemaker, that's a really good monitoring device. It tells you what's going on in your heart all the time. Okay, so what people wanted to know was, is there a temporal relationship between when you have your stroke and when you have your AF? Because if AF causes the stroke, then surely there must be a temporal relationship. There must be AF, stroke. It can't be AF a year ago, stroke now. You can't blame the AF then, can you? So they were really interested in looking at that. And so the red line here is when they had their stroke. And those little black squiggles are when they had their AF. And really, there's no consistent relationship. Some people get tons of AF before, several months. These are months from the event. So 18 months ago, some people had their AF, and now they have the stroke. Some people have their AF after they've had their stroke. So again, started pointing to the fact that maybe AF is a marker of the person more likely to have a stroke rather than being the cause of the stroke. Again, very important, because if you start thinking of it like this, you start understanding that maybe taking away the AF doesn't take away my stroke risk. So a lot of people talk about ablations, this and that, etc. It does not take away your stroke risk because of this. People think, I'm no longer in AF, my stroke, I don't need to worry. No, the stroke risk persists.
Does the health authority believe that? NHS England?
I don't think they've, no, I don't think so. I mean, they do it in practice. I don't think anyone has vocalized it as such, but I'll try and, I think the important thing to understand is this concept of risk. Okay, so you have this condition, okay, what is your risk? How do you calculate risk? Well, risk is like a hole in the ground, okay, that you may or may not fall into. The only thing, this guy is walking towards this, how he feels has no impact on whether he falls in the ground or not. The only thing that has an impact on whether he falls in the ground is how big the hole is. So how do you calculate the size of the hole? Well, you let 100 people walk, count how many fell, and on the basis of that, you calculate the size of the hole, right? So that's what they did. And this is how they calculated. And this is what we do now. We calculate the risk by giving you a score. This is called the CHADS2-VASC score. And what they say is, if you have a score of 0, i.e. you're not diabetic, you don't have high blood pressure, you never had a previous stroke, etc., your risk is very low, which is exactly what we say. The lone AF people, the people who were young, who had no comorbidities, don't have strokes. We're practicing that. But no one vocalizes it as such. No one makes people understand that. But as your comorbidities increase, your risk per year goes up substantially. With every additional comorbidity, your risk almost doubles. And here's some really interesting data. which is, if you took this, let's say you've never had AF. This is for patients who've had AF. This is when this thing comes out of the drawer, right, people? But if you've never had AF, could this predict your risk of strokes? Right? Because we've only become interested in this since we started seeing AF. But let's say AF isn't the cause of stroke. So the comorbidities are, what would happen if you never had AF but you had those things? Does that predict the risk of strokes? Here's a nice publication which shows that actually, even if you've never had AF, calculating your risk, your comorbidities are what increase your risk of stroke. So there will be a time when it doesn't really matter whether you have ever had AF or not. If you have all these comorbidities, they will count it as being high enough and you'll probably be anticoagulated. But that's the interesting kind of thing that's coming out. So the question then is, well, when we're talking about something and what it can, how it can impact on our management, the first thing we have to say is, how do I reduce the size of the manhole for me, right? And there are only two ways that you reduce the size of the manhole. Number one, lifestyle. So preventing other comorbidities from coming along. If you have diabetes, controlling that, not developing high blood pressure, etc. That makes a big difference. And anticoagulation is the other thing. The question is, why anticoagulation? What is this thing about anticoagulation? Well, there is the current theory was that in atrial fibrillation, what happens is that the heart is not beating as effectively when you're fibrillating, and because it's not beating as effectively, you can form a blood clot. And that blood clot can then get dislodged, go to the brain, and that could cause the stroke, right? So that is why the anticoagulation thing came about. People started recommending anticoagulation. And there is no doubt that anticoagulation reduces risks of stroke by 60%. But that wouldn't fit with what I've just told you, because I've just said that the atrial fibrillation doesn't seem to have any relationship with the time when you have the stroke. So if it was about this kind of fibrillation and the blood not coming through and blood clot forming, then surely you would expect a temporal relationship between the time when you have the stroke and the atrial fibrillation. So how does that work? What is the theory behind that? And the answer is that we are beginning to realize that we made a fundamental mistake. What we thought was that when you go into atrial fibrillation, your atria aren't working. What we assumed was that when you are not in atrial fibrillation, your atria are working beautifully. And the reality is that people who have comorbidities, high blood pressure, diabetes, etc., their atria start weakening a long time before they develop atrial fibrillation. So maybe the clot forms at that time. And weak atria will cause clot formation, and weak atria will fibrillate, but there doesn't necessarily have to be any relationship between the two. So that's interesting. The other thing which is really interesting is that there is no doubt that some people feel atrial fibrillation and feel it terribly. And there are other people who don't even know they've been in atrial fibrillation. How does that happen? Why is that? And I guess it boils down to this, because this theory would explain it. If you have bad atria, which weren't doing very much anyway, your body adapted to that over a number of years, and when they fibrillate, you don't notice a difference because they weren't doing very much anyway. Whereas those people who are younger, who are healthier, who are like finely honed machines, they're reliant on the atria. When their atria goes out, their atria were healthy. Suddenly, when the atria goes out of sync, they notice every little bit and they are really troubled. And that is the relationship between this. So in terms of in terms of how, so now I've said to you, well, atrial fibrillation can possibly shorten lifespan. All treatment has to be based, one of your treatment strategies has to be based around how you improve lifespan. Of course, lifestyle will reduce the risk of strokes, it reduces the risk of sudden death, it reduces heart failure, it improves quality of life, and it has no side effects. And I'll talk you through some of the lifestyle things that work. Then there is anticoagulation. Anticoagulation is like putting a little metal plate on the hole, and it covers the hole by about 60%. It reduces the risk of strokes by 60%. It does not improve quality of life. It may paradoxically make quality of life worse because it's a hassle. And it has the risks of bleeding and possible side effects. In terms of lifestyle, I'll talk to you a lot in detail, but lifestyle basically is 4 things: nutrition, sleep, exercise, and stress. So addressing all 4 aspects allows you to work on lifestyle. In terms of anticoagulation, as we say, the aspirin is not an anticoagulant. Aspirin will only reduce your risk by 20%. Anticoagulants are warfarin, which is rat poison, or some of the newer agents, NOACs, which don't require the monitoring required with warfarin. Some people worry about bleeding. In general, the bleeding risks are much lower than the stroke risks. Okay, but if you are worried about bleeding, then they have this mnemonic called the Hasbled score, which is things that your doctor should be thinking about tackling before he puts you on anticoagulants. Not things that should detract your doctor from putting you on anticoagulants, but things that could actually reduce your risk of bleeding. So if your blood pressure is uncontrolled, then tackling that, controlling the blood pressure aggressively first, means a lower bleeding risk. Again, if you have abnormal liver, kidney function, if you're using alcohol on a regular basis, if you have medications which could interfere, tackling all those would make a difference. And currently, the recommendation is that even if you have one comorbidity or you're above the age of 65, you should be anticoagulated. And as discussed, that anticoagulation has to go on for life, because your risk can only ever go up, because you can only ever get older. You can only ever develop diabetes. If you don't have diabetes, you can't take it away. These are the current recommendations. I was really interested in looking at this because I thought to myself, well, I asked my friends, I said, in my hospital, I said, if you developed atrial fibrillation, what would you want? And they all put their hands up and they said, we would want one of the newer agents. We don't want warfarin, thank you. But I found that 50% of my patients were coming back on warfarin. And I said, well, either we know something, because if we don't want it, we want the other one. Why are our patients still choosing, 50% of our patients still choosing warfarin? Is it that we know something we haven't told them, or is it that they know something they haven't told us, right? So I decided to find out, and basically I said, well, why did you choose the different agents? So the patients who choose these new agents, the NOACs they're called, or the DOACs, why did you choose them? And the patient said, oh, because we were told we wouldn't require any blood tests and they are inherently far more convenient for us, so it makes sense. And then we said to those people who were taking the warfarin, why did you choose yours? Why did you choose warfarin? This is what we were really interested in. And most of them said, oh, because it's reversible. So inherently it's safer in some way. Actually, this is wrong. When you look at all the data, these are some studies, there's a sort of chart. When we look at the data, they're both equally good at preventing strokes. Warfarin and NOACs are equally good at preventing strokes. However, when you look in terms of bleeding, this tells you that those two little marks tell you that the NOACs are far better. The things that are far less likely to happen, 50% less likely to happen if you take a NOAC, is a bleed in the head. So actually the agents are significantly safer than warfarin. And so they came about this thing where they said, well, yeah, but what about the reversal agent? There's no antidote. There's no antidote to this. Well, actually, the first thing is, does an antidote matter if you're going to, if you're going to bleed, you're going to bleed, right? No antidote suddenly going to transform you if you're at home and you have to because you only need a little bit about bleeding in the head to sustain permanent damage. In some ways, at that point, you'd rather just not live, because of the damage that's happened. So the question is it better to have an antidote which someone can offer you? It's like going and crossing a bridge, you're more likely to fall off and then hope that there'll be an ambulance to take you to hospital at the bottom, or to cross a bridge that you're less likely to fall off in the first instance. So that's the idea. So, this antidote thing is a load of rubbish. In any case, there are antidotes now. So there is no real good reason why anyone should plump for warfarin over the NOACs. I think warfarin has advantages. It's cost effective. It is, if you have good warfarin control, it's as good as anything else. It's tried and tested. It's reversible. It can be used in all sorts of patients with kidney disease, patients with artificial valves, etc. But it does take time to work. On average, it takes about 30 odd days to start working, to get in the right range. It can be erratic. It requires lots of blood testing. People can't take different types of foods that they enjoy with it, etc. With the newer ones, the big advantage is 50% reduced risk of bleeding in the head. That makes it much safer. No blood tests required. Very effective reversal agent, at least for one of them. They work very quickly, almost immediately, and they provide consistent anticoagulation. But they cannot be used in certain conditions like patients who have kidney disease, pregnant women, patients who have artificial valves, and they're not tried and tested like warfarin, i.e. they just haven't been around for as long. So now the current guidance is that if you are on warfarin, you are well within your right to go and say to your doctor, I don't fancy this, I'd rather take just a pill every day, no blood tests, etc. What about natural anticoagulants? A lot of people ask me about that. They say, well, what about natural anticoagulants? We have turmeric, we have motherwort, we have hawthorn, we have garlic, we have nattokinase, So I get this all the time, and I get criticized all the time because I discourage people against this. And the simple thing is this, okay? I don't recommend anticoagulants because they anticoagulate. I recommend them because they prevent strokes. If something thickened your blood but prevented strokes, I'd be very happy to prescribe that. That is the outcome I want. The reality is, when you take these medications, you will never know. You will never know whether you've done yourself good by taking these. You will know if you've done yourself harm. But if you don't have a stroke, how do you know that it was taking this medication that's prevented your stroke, or whether you'd have had a stroke anyway? So you will never know. So the only way to base your decision making is to study a bunch of other people and say, well, did they have strokes, right? So for that, you need evidence. You need to have a research study, and the bigger the number of people it's been tried on, the better it is. There is no study so far which has looked at thousands and thousands of people on nattokinase or turmeric or motherwort to inform us that these are a safe alternative. And on the basis of that, we cannot recommend them. I'm not against the idea of if something came along and showed, and we had that evidence, do they prevent strokes? If they prevent strokes, great. I'm all for it. But at this point in time, we don't have that. I think so that, does everyone understand how it affects your lifespan and what you can do about the lifespan bit? Excellent. So the next thing is quality of life. Quality of life is determined by our symptoms. There's two things I'd say about quality of life. Quality of life does not require evidence. A lot of people say, well, something, how do I know it works? In terms of quality of life, well, you try it. If it works, it works. It's your quality of life has to be measured by your own yardstick, right? So the fact that it improved quality of life in 2,000 Siberian men doesn't really have any bearing on me. My quality of life depends on my yardstick. So quality of life is, AF can cause palpitations, effort intolerance, breathlessness, chest pain, dizziness. I don't want to take up Emma's time. Fatigue. Now, it's worth knowing that it's like a ladder, okay? So at the bottom, you have normal rate, normal rhythm. This is what we're in at the moment, sinus rhythm. When you go into AF, you go into an abnormal rhythm, but you can be at a normal rate, so your heart may not go very fast. And those people don't seem to get as many symptoms as those people who also go into an abnormal rate. So ideally, the counsel of perfection when you're trying to treat it is to get them back to normal rate, normal rhythm. But if you can't, you can make a substantial difference to the person's quality of life just by getting them from the top box to the second box. And as I say, symptoms are due to disturbance in rate, disturbance in rhythm, or both. So in terms of modifying symptoms, how do you get symptoms better? Well, you can try and get the patient from the top right to the bottom. You know, they've got their symptoms, try and get them back into sinus rhythm. That is ideal, but that is difficult. So what can you do to try and get those people back into rhythm? Well, you can use medications sometimes, particularly for those people who go in and out. So you can use medications to keep them in. You can do this thing called cardioversion, which is where you shock the heart under general anesthetic if they're continuously in it. Or you can do something called an ablation, which is now becoming more and more sort of used, where you can identify areas from where these impulses are coming from, which are around the pulmonary veins, and zap around them. This is it's like corralling a bunch of horses, you know. The problem is if you don't do a good enough job, a horse can escape, and then you get the AF again. But people are gaining more and more expertise with this. The first one was done in 1999, so we're not even 20 years away. So we don't know what the long-term effects of burning things in the heart are at this point in time, but everyone seems to think it's the best thing since sliced bread. What I do know is that none of these things are going to be successful unless you address the things that led to your AF in the first place. So let's say those things don't work. So what else can you do? Well, can you get them from the second rung to the first rung, you know, from fast rate to normal rate, and leave them in atrial fibrillation? So in that sense, we use things like beta blockers, calcium blockers, digoxin. But a novel approach now is that what you can do is one of the things you can do is, at this point in time, what's happening is that the 15 guys at the top aren't working. The 85 guys are sort of not responding because they don't have anyone telling them what to do. You can break the connection between the top guys and the bottom guys. And then you can put a pacemaker in the bottom to tell the bottom guys what to do. So the top guys still continue to fibrillate, but the bottom guys do what the pacemaker tells it to. This is called AV node ablation and pacemaker. The advantage is it substantially improves quality of life. The disadvantage is that you're then dependent on a pacemaker. Now the question is, what is, in terms of long-term impact, what is the advantage? Which one is better for our lifespan? Is it better to go back into sinus rhythm, or is it better to just control the heart rate and leave us in AF? What offers a better outcome in the long run? And the answer is there's no difference. This was a study called the AFFIRM study, where they found that both strategies don't seem to, there's not one strategy which is better in terms of overall patient outcome. So what other things can you do? What other lifestyle things work for AF? Because whilst I've talked to you about this, you'll get this from a lot of places. What I was interested in sort of empowering you to say, well, what other lifestyle changes work? AF and magnesium is interesting because low serum magnesium, 75% of the population are deficient in magnesium. No one knows enough about magnesium. You can't measure it on the blood test and get an accurate estimation. But low serum magnesium has been linked to the development of atrial fibrillation. And I certainly have a bunch of people who take magnesium and have said that their AF has gotten less. What about this? Goal-directed weight management. So atrial fibrillation tends to occur in patients who carry extra weight. And actually, if you get them to lose weight, so these are groups where on the y-axis you have ablation-free, drug-free AF freedom, right? So how many patients didn't require ablation or drugs for their AF and were free of AF? And these three lines refer to how much weight they've lost, okay? So the red line indicates those people who've lost 10% of their body weight through a weight loss program, and they did the best. And then second is 3 to 9%, that's the blue line, and the purple line is less than 3%. So people who lose more than 10% of their body weight seem to do really well in terms of less AF and total AF freedom. What about exercise? Aerobic exercise is exceptionally good for AF. Here is a study which shows how much exercise helps. These are two groups. This is a group of people who underwent 3 months, I think, of exercise. This is a control group, and you can see how much AF, the time in AF gets a lot less in the group who've gone through exercise. So exercising is exceptionally good. And some of these people exercised whilst they were in AF. So that is not a contraindication to exercise. 1 in 2 people with AF have sleep apnea, underlying sleep apnea. 1 in 5 people in this room have underlying sleep apnea. Only 1 of you will have been diagnosed. 1 in 5 people. So if you have sleep apnea will increase your risk of diabetes, will increase your risk of high blood pressure, will increase your risk of AF, will increase your risk of heart attack, stroke, sudden death, will increase your risk of road traffic accidents, destroys your quality of life. So tackling your sleep apnea makes a huge difference, not only to your overall length of life, but will reduce the AF burden. But of course, if you went and had an ablation and you had sleep apnea and you didn't do something about the sleep apnea, then the AF is much more likely to come back. What about this? Acupuncture. This was an interesting thing. Does acupuncture help in episodes of AF? And this was a really interesting study where they took only a small number of patients. These are patients who'd had a cardioversion, and what they wanted to do was, if you put them through a course of acupuncture, do they get less likelihood of their AF coming back? And yes, very definitely so. And in those people who have AF which comes and goes, going through acupuncture seems to make a substantial difference, as good as any medication. Small studies, not a big study. You cannot say, oh, this is the way forward, but we should be open to these ideas. We should be open to embracing this if they work, if they're proven to work. Yoga seems to work really well as well. So if patients who go through yoga seem to have less symptoms, less arrhythmia burdens, slower heart rates, less blood pressure, lower anxiety and depression scores, and a better quality of life. In men, testosterone. So one of the things that became really interesting is, as we get older, we get more AF, but as we get older, we lose testosterone as men. So could it be the testosterone that is in some way protecting us against developing AF? And lo and behold, yes, if patients who have lower testosterone get more AF, and actually if you correct their testosterone, they get less AF. This is a really interesting study. Triggering of symptomatic AF by negative emotion. So someone wanted to see, does stress and your mindset have an impact on how much AF you get? And what they found, which was really interesting, was that there was a significant increase in the likelihood of AF in association with endorsement of sadness, anxiety, anger, and stress. But the likelihood of AF was 85% lower after reports of happiness. So yeah, that's a run through AF, and if you have any questions, I'll happily take them. Great, thank you so much.